Well, good day. I'm Keith Altshuler, and I'm going to be doing the makeup video for the Spring Forum today. And as usual, the agenda is fairly standard. You can see that I want to talk about the balanced scorecard numbers for 2013 and first quarter of 14. I want to talk in depth a bit about our safety survey and plan, and give a brief update on the market and facility update, and finish, of course, with the Connect to Purpose story. So as you recall, last year we struggled with growth on adjusted admissions pretty much all year. You can see we ended up slightly below budget at 32,498 adjusted admissions. Those are that combination of inpatient, outpatient number that gives us an idea of our volumes in the hospital. And you can see in 14, 7716 versus 8278, we're still a bit below. And my point here is that we continue to see reductions and declines in the market relative to overall business volume. In fact, if you look at it throughout the market, not just us, but UT and all the other hospitals in the area, we've dropped about enough adjusted admissions to equate to a Methodist Medical Center. Now, that's significant, and it's something that we continue to watch. Obviously, a lot of reasons, but the biggest reason is all the reform issues that are going on and the contracted market strategies that are being employed by the payers, the ACOs, and others to reduce utilization. Now, service, we ended up, I think, very good last year. You can see the HCAHPS index scores were 1.0. We struggled to get to 1. 1 is sort of where, we see the national and state markets going. We made it there. You can see with respect to the PRC surveys that we're very close to our 80th percentile numbers, but not quite there in all of our areas. Recall, though, that those numbers are percentile excellent scores, and if you look at our very goods and goods plus the percent excellent, we're doing very well, but still have some work to do. If you look at where we are the first quarter, again, we've had some volume issues that we've been struggling with, and the HCAHPS score is, again, as we normally see, below 1 at 0.995. We've got to continue to work on that. And again, our PRC scores are lower than what our budgets were in terms of 80th percentile expectations, but we're within striking distance if we continue to work very diligently toward those goals. Again, we continue to see that areas of improvement for PRC would include being quiet at night on the floors. Obviously, we've had some issues with volumes, and so responsiveness of staff has been below target, and communications with nurses, which I think is related to the volume, has been a bit below our targets as well. Now, again, we've been accustomed to seeing very good quality numbers at the hospital. You can see our reduction of harm events in 2013 was very significantly below our budget. And these are those events that include serious falls, medication injuries, and other issues such as infection rates and so forth around the facility. 2014, we've implemented again some new strategies with very aggressive goals, and we appear to be making some headway in 2014 relative to harm events. Our quality numbers as evidence-based information through core measures look very strong in 2013. We had 99.7% compliance with those core measures versus a budget of 98.5, which is excellent. And you can see we still have some work to do on doing core measures 100% of the time. We wound up at 60% versus our budget of 75, but we continue to make good progress here as well. And obviously on our mortality rates, they're much better than what we would have been expected at 0.5 versus 0.789. And again, anything below 1 is considered very good. So if you look at 14, we've dropped a little bit in core measure compliance. I think some of the skip measures were down a bit. We've had some issues with vaccinations, especially pneumonia requirements. Hopefully we can get that on track this year and improve those core measures back to where we've been accustomed to generating. If you look at turnover, we didn't quite meet the voluntary turnover rates for last year. We were at 13.7. We'd budgeted to be at 11. Currently, we're right on track with our voluntary turnover rates in 2014, but obviously the lower the number there, the better. So if you look at our financial performance last year, we actually performed quite well. Even though our length of stay was a little higher than budget at 5.68 versus 5.2, because of our good performance on volumes and all the money that we got back from meaningful use from the government, we were able to exceed our budget at $21.7 million versus $19.8 million. So that's very good. I would remind everybody, though, that the system itself was basically breaking even last year because of all the changes, and we just need to remember that the more that we can do effectively here, the better that we help the system going forward. You can look at our length of stay through 2014, and with all the flu and the things we had, we obviously are higher than what we'd anticipated and higher than prior year at 587, but that is coming down, and it looks like it's getting more normalized as we get through the summer months. And I'm very happy to say that from a financial standpoint, the first part of 2014, we're pretty much tracking on budget, which is good for us because we're usually lagging at the first part of the year. This year, we're very close to where we budgeted, which is a good sign. Now, I'd like to shift, if I could, to our safety survey results from last year. And we're embarking upon a new survey here in June, so I think it's very important that we spend some time on looking at where we were last year. And I'll start off by showing on the very left-hand table, you can see 2011 national data is projected. In the middle column, the 2012 Tennessee data is there, and you can see Fort Sanders composite scores relative to those two other databases on the very far right. So when we look at overall perceptions of safety and whether or not we agreed with that or not overall at the hospital, you can see we're lagging both national and state data in terms of how we're perceived in terms of managing safety at our hospital. And that's concerning. That's something that I would encourage all of us to get involved on to improve, because that's generally one of our major strategies and one of our major reasons for being here at the hospital is to be safe and to improve the care to our patients that come to us. If you look at some of the dimensions of that survey, I'm going to go through these because it sort of tells us where the issues are. We're doing a pretty good job in terms of reporting events, very close to, if not exceeding, national and state data. If you look at supervisor and manager expectations and actions promoting patient safety, we're lagging both of those databases, and so we've got to improve there. Do we learn from the mistakes we made through the organizational learning and continuous improvement process? It appears as if we're pretty much in line with both of those other databases. If you look at teamwork within the units, you can see that we've got a bit to go, but still, I think, fairly good results. Communication openness, we've got some work to do there. You can see 56% versus 62% strongly agreeing. And feedback and communication about errors, you can see there we pretty much are in line with the database in terms of reporting and having feedback on the errors that do happen in the hospital. We've got a lot of work to do, I think, in terms of non-punitive responses to those errors. You can see there we're at 37% versus 44% and 45% perceived agreeing with that cultural question. Staffing, too, appears to be an issue of concern for all of us. You can see there we're at 47% versus 56% and 58% respectively on the national and state data. Hospital management support for safety, you can see there we're lagging both the state and national data too, which also concerns me. Teamwork across the hospital continues to be, I think, fair relative to the databases, but we do have some issues that continue, as you would expect, in hospital handoffs and transitions, 40% versus the 45% and 48% respectively. So how do we use this data? How have we used this data to try to improve from last year to this year? You can see on the supervisor and manager expectations and actions promoting patient safety, we've done a lot communication-wise within the management team about improving safety and being alerted to safety issues on a daily basis. We do have daily huddles now, safety huddles that occur at 11 o'clock. You're all welcome to come if you want. They don't take that long, but we get an update from everybody in the hospital, the major areas, about things that could be safety issues we all need to know about and report. We try to get some articles on Regional Review this past year, and we'll continue to, about safety issues. And we've had a lot of training opportunities in both from risk management, from Chico Messer and safety around the hospital, and how to manage large-scale safety issues through FEMA training and those kinds of things managerially. We have initiated also a safety hotline, a hotline that gets directly to me or the administrator in charge if you see or are aware of something from a safety perspective that you need immediate attention to. It's been used, I think, fairly frequently, and we've been able to really go in and try to intercede on most of those issues that we could effectively change right then based on your input. We also have a very, I think, active sharps injury team now. We're looking at sharps injuries to make sure that we mitigate those through safety sharps and through processes and procedures that we're adhering to in terms of reducing those. It's an ongoing issue, but it's one that I'm also very concerned about, and I'm seeing some good progress being made. With respect to non-punitive response to arrows, we've had a lot of discussion managerially about why that's occurring, how it occurs, and I will say to you that I believe, as do the rest of the managers, that most all of our safety issues are really the result of process breakdowns or opportunities to improve processes. No one comes in at all and has a thought about not being safe. It's just our processes, especially when we get busy, tend to break down sometimes and cause most of our issues. So we're trying to talk about how do we promote this just culture philosophy. What I mean by that is we understand that most of these are process issues, but if you repeatedly don't follow process, and if you repeatedly try to cut corners and it puts our patients in harm's way, then there must be accountability. And accountability at my level, accountability at everyone's level, because this is a job we all have to take as job one. As you look at staffing issues, you can see that obviously we do have issues of concern on staffing. I think one of the biggest issues we see around the house is that we can't always keep core staffing levels appropriately. And when we get down through either FMLA issues or sickness or other things that happen, we're not able to get back up as quick and flex up. And so to try to fix that, we're looking at the bolstering of our staffing pools. We've had numerous meetings with HR corporately to try to help us in this regard. It takes a while to get all of that done, but we are dedicated to fixing it. I think it's a long-term process, but one of which I'm very committed to fix, to make sure that we've got appropriate staffing in all of our areas for patient safety, for our staff and patients. The other thing we've begun to do is talk about communication relative to benchmarks and staffing standards throughout the areas. We've had several areas this year where we've asked the industrial engineers to come in and help us work through that, because we do believe that the benchmarks are not taking into account everything that we think they should, given our patient and volume mixes. And so we will continue to do that as we continue to have concerns in different areas about benchmarks and how it's really playing out. The other thing we're doing in terms of communication openness is we continue to encourage you to use the SIR process to report these patient near misses and problems. We're tracking those annually, quarterly. We're looking at them as a management team. We're trying to look for trends, so if you don't report, we can't trend that. And of course, the safety hotline is something I would encourage you to use if you know or think you know that there are issues going on that we need to be made aware of. I also would encourage you during our rounds, whether it be your manager, your supervisor, myself, or any of the managers, to bring up safety issues in safety rounds. I had something last year where for many, many months there had been an issue with some of our technology and we couldn't get that done, evidently. And so I got involved, and as a group we finally got it done, but it took a lot of our involvement to make sure it happened, and sometimes these things are very complex and it takes all of us as a village to get those things corrected, but we did, and we picked that up through regular rounding in the departments. If you look now, going to the facility and market update, just a couple of things I want to again refresh your memory on. We did add 2 facilities to the system in the first quarter of this year. Cumberland County Hospital out in Crossville, of course, became part of Covenant the first quarter. And Claiborne County Hospital did, I think, in April as well. And I'll tell you, I've been to Claiborne and to Cumberland, Claiborne more recently, and the folks out there are very, very eager to be part of our system and our team. They're very eager to work with regional to try to send patients our way for specialty needs and so forth, and they're very, very hungry for information, for equipment and things that maybe we could lend to them or give to them that they don't have, that we definitely have surplus that we could do. So I think that's going to be, both of those hospitals are great additions to our system. They're going to make us both stronger, and I would encourage you to reach out to your counterparts there and welcome them to the system if you have a chance. Now, We just got through the Joint Commission, as you know. We did excellent there, and we must have done so good that CMS came back in to validate the response of Joint Commission. And that was unannounced. It came in the middle of our forums last time. We had to cut them short. But again, it's one of those things that you can't control. We did excellent there as well. Had no significant findings. We're not even required to do a follow-up report. But on the findings that we had, we are working through those and making sure that we're up to snuff on everything from a CMS perspective as well as Joint Commission perspective. CARF also for rehab was an excellent survey this year, and I commend everybody in rehab for all the hard work you did again to take care of all those numerous CARF certifications. Let me move then to new services. Just so you're aware, we are starting and have started through the last couple of months several new programs. The neurohospitalist program has started with Dr. Hoare here as the first of two physicians in the neurohospitalist program. Dr. Moore, a neurointensivist, should be here sometime middle of June, and so we'll have two physicians, 7 on, 7 off, that'll always be in touch or at the hospital with our major services to ensure management of stroke care is top notch. We also will be starting a bariatric surgery program for our bariatric patients. That will start sometime probably the 1st of July, and we'll be putting those patients on one of the floors, and hopefully we'll have a great program here to help patients in need of bariatric care. And we've gotten through CPOE, which was something I was really struggling with. Physicians even struggling more, and I'm sure you all have had your moments as well. But I think that process has actually gone as smooth as we could have hoped. This is a work in process. The software that we have now is not going to be the end product. And obviously we've seen a lot of improvement opportunities, and we'll be working on those as we speak. But thank you all for all the hard work that you continue to put into this process and for making this a successful implementation. A couple of issues on physician recruitment. We'll shortly be seeing several new surgeons that will be joining Premier Surgery Center. Bariatric surgeons, we've got Dr. Kimsey, who will be coming in as a surgical oncologist. We have an abdominal reconstructionist that will be starting with Premier as well. I believe those folks are starting in August. We have Dr. Folk, who's a new OBGYN that will be starting as well this summer. So be on the alert for new physicians, welcome them. They're going to be here to take over as we have more and more retirements in some of our surgical service line, and I'm looking forward to getting them transitioned and getting them to continue to provide the care that our previous surgeons have for so many years. And now I'd like to turn over to see a Connect to Purpose story. I think I would remind you, since I won't talk to you after this, that every time that we have an opportunity to have great patient care, excellent patient care with our patients, you never know what it'll do to the future progression of that patient in terms of their livelihood, their professional aspirations, and their empathy for patients going forward. And I think that this video does a lot to sort of show how great and excellent care and empathy can really influence patients and future professionals' lives.
When I was little, I knocked over a chair on my foot, and it caused a big bruise. And it started to grow really quickly. And we went to a lot of doctors in 6 weeks, and they said that it was just a bruise, and finally one diagnosed it. It was infantile fibrosarcoma, and only 15 kids have ever been diagnosed with it. And I think 12 are still living and 3 have died. Then they did reconstructive surgery and pulled all the cancerous tissue out, had a big margin of error to make sure it was all gone, and then it was reconstructed, all except for the tendons. I just lost the tendons and a couple nerves. And then I came back to Thompson for just checkups to make sure it didn't come back, all the way until I was 13, and I was completely diagnosed, free and clean. Me being 18 now, looking back on it, it just kind of makes me feel like I'm a unique individual because I was so rare. I had more of a chance of winning the lottery 2 or 3 times over than getting my cancer, and fighting through it and just defeating it, even as a small child, like, it still means a lot to me. I volunteer at Thompson Cancer Center to help give back to what they did to me. They helped cure me and help me defeat this cancer. I help because I want to build a relationship with the hospital and see how it is and help people the way they help me. Within the next year, I'd like to start Maryville College and go ahead and get my pre-med degree. Then I plan to move out to Arizona and go to University of Arizona and get my medical degree, and then hopefully from there go on and get my oncology degree. Me going into oncology, I feel like I can help others because I've been through it, I've fought it, and I've defeated it just like they can.